We're recording the webinar so we can post it on our website later. So as people start arriving, we've got about 30 people in attendance now. We'll just move forward here and proceed with the webinar. The title of this webinar is Relative Efficacy of Coherence Neurofeedback for Seizure Disorders. I would like to say that most of this was presented at this past year's ISNR conference. The findings from this have not yet been published, but are in preparation. My name is Robert Coben. I'm a PhD licensed psychologist, neuropsychologist, and the co-director of Integrated Neuroscience Services. So the main topic of the webinar relates to seizures and seizures disorders. And some of this will just be background information. I'm sure many of you are familiar with this. A seizure is a sudden surge of electrical activity in the brain that becomes uncontrolled and unregulated for a period of time by other brain regions. Epilepsy, which is a diagnostic classification of a group of seizures, is the fourth common neurological disorder and affects people of all ages. Epilepsy, by definition, is the same thing as a seizure disorder. So a type of epilepsy is diagnosed when someone has repeated seizures. The number of people with epilepsy using prevalence numbers ranges from slightly over 1 million to almost 3 million individuals, or 5 to 8.5 out of every 1,000 people. This is likely an underestimation, as there are many people with seizures or seizure disorders that are not even designated as having full-blown epilepsy. Seizures are generally broken down into categories of partial and generalized seizures. Generalized seizures include those like absence seizures, tonic-clonic seizures, which are often associated in coincidence with grand mal seizures, myoclonic and atonic seizures. In a generalized seizure, the spread of seizure activity goes across both hemispheres, and thus involves multiple brain regions and can actually be risky for the individual, can actually cause further damage in the brain. Partial seizures are simple and complex partial seizures, and the reason they're called partial seizures is that they remain in one region of the brain alone, typically only on one side of the brain. They do not spread across the corpus callosum to the other side of the brain. Partial seizures are not considered as dangerous, but they certainly can impair functioning. Generalized seizures almost always are treated medically because the disruption to brain activity and potential destruction from those needs to be avoided. Partial seizures can be treated medically or pharmacologically, sometimes or not. This is my favorite slide in the entire 47 slides. But this is Homer Simpson portraying with the phases of a generalized or tonic-clonic seizure, where it usually starts with an aura of some type or prodromal phase of the seizure, which can be associated with dizziness, confusion, visual auditory hallucinations. Then the tonic phase, which is a tensing up of skeletal muscles and often losing consciousness at that point. There is often urinary incontinence associated with loss of consciousness. The clonic phase then is a series of motor convulsions that can be violent and uncontrollable if you've ever seen them, that last for a period of time, and then the seizure completes itself. There is then a post-ictal state associated with confusion, amnesia, and potentially sleep or fatigue that can last from minutes to hours. There are several different types of partial seizures, including simple partial seizures depending on the region of the brain involved that impact different portions of the brain. So you can have just tingling in portions of the body on one side of the body. You can have focal motor seizures where only one extremity or limb will move. You can have visual seizures where there are hallucinations or blurring or flashes of lights. You can have autonomic seizures where there is sweating, flushing, and other autonomic sensations, or you can have only auditory seizures where someone has auditory hallucinations or hears ringing or other noises. In complex partial seizures, you'll usually experience a combination of many of the above, including full-formed auditory or visual hallucinations, olfactory hallucinations, other psychomotor, and other even impairments of consciousness, such as a blank look, loss of attention, a deja vu feeling like the person has been there before, or fear or anxiety. And of course, in any of these seizures, you can have a combination of these. Since these are not fully motor seizures, many times they can go unnoticed by other people, which is important. If we look at the full range of types of seizures, generalized seizures tend to occupy the minority of seizures, and full-blown grand mal seizures or tonic-clonic seizures only about 1/4 of all seizure types. And partial, especially complex partial seizures, are the most common. In a seizure event, as you can see on the top portion of this slide, we have discharges of electrographic activity. I'll just kind of get a pointer here so I can point to it. And you can see these bursts of activity. This is in a bipolar montage on the EEG at P301, T501. And of course, you can see some remnants of activity in other regions, but that's with the focal location of the seizure itself. On the bottom graph below, you see a display of the seizure event in a spike detection program that shows you point 0 in the middle here. This is the seizure occurrence. These are 10 millisecond blocks prior to the seizure and 10 second milliblocks afterwards. And you see that the T5, P3 area, even to O1, is the focal location. And interestingly, what you see is heightened activity in that location, and in surrounding areas, a significant deactivation of activity. And if you were to compare what happens between these two general regions of the brain, they are diametrically opposed to each other in terms of EEG activity, with one being positive and one in a negative direction or disconnected from each other. That concept will be very important and will come in later in what we'll talk about. This was actually a patient of mine who had significant language dysfunction associated with partial seizures and could not read at the age of 9 until the seizures were treated successfully. This is another view of another type of seizure occurring in this individual. You can see here with a focal display at about F3, C3, and T3. And you can see delta and theta discharge associated with some mild alpha discharge as well. Typically, the spike event itself will be associated with alpha or low beta discharges, and the wave, the large wave that follows that event, will typically be seen in the delta and theta range. So you can detect seizure activity by looking at combinations of those types of frequencies of activity. Seizures occurring in autism spectrum disorder are quite significant. I've heard one neurosurgeon say that the greatest prevalence of seizure disorders in any group is in ASD other than epilepsy. There has been research to show that about 1 out of every 3 individuals diagnosed with ASD has a diagnosed seizure disorder, and many others appear to have paroxysmal and spike and wave discharges that are not definitively diagnosed as a seizure disorder. So in the spike and wave events of these individuals, you can have as high as 60% occurrence, which is why routine EEG and search for this type of activity is very important, obviously for anyone with epilepsy, seizure disorders, autism, and then other conditions that can be impacted as well. This is another display of an individual with seizure events. So there is a software suite that we use that it's not a typical QEEG software program, but can detect seizure events. The one we use is the Insight 2 spike review detection program made by a company called Persist, Persyst. It's fairly expensive, but the algorithm they use is about 98% accurate in detecting seizure events. And you can see it gives you a display of seizure events where they're occurring, and you can even get a graphical display again. So again, what I want to highlight is the seizure event occurring here, and notice how the regions anterior and posterior to it are in diametrically opposed activity in terms of positivity or negativity, which means that connectivity across these regions is going to be extremely low. It's going to be very high where the seizure event occurs, but very low between adjacent regions that may help to regulate that activity. And again, we will return to that type of information. So the basic theory involved in what leads to a seizure event is a seizure is a hyperexcitability and a hypersynchronization of neuronal assemblies. The feedback loop that regulates neuronal stability is disrupted. So you note in a neuronal system, there are positive and negative valences that lead to stabilization of this feedback loop. If these are disrupted in one way or another, usually what happens is the inhibition or the regulatory control over activity is somehow disrupted, and the surge of EEG activity then is dysregulated and a seizure results. What happens again is in the region of the seizure activity, there then becomes a hyperexcitability or hypersynchronization or hyperconnectivity, but the regions around it have quite the opposite. They have low regions of connectivity that have allowed for this event to have occurred. So the theory that has been promulgated is that if you can regulate this connectivity, you can regulate seizure activity. So there is a balance of excitation and inhibition. And in fact, we know there are neurochemical properties associated with this, including glutamate and GABA, respectively. We see hyperexcitation or hypoinhibition, as we've talked about, that lead to seizure activity. So in excitation, there's too much activity. In over-inhibition, there's too little. When we lose inhibition, the excitation takes over, and we get this overexcited, hypersynchronized, hyperconnected region of the brain that forms this discharge of activity that we call a seizure. Seizure medication facilitates GABA, which facilitates greater inhibition and regulation of these circuits. But there may be other ways, including neurofeedback techniques, that can also facilitate this inhibition or regulation of these systems to help prevent seizure events as well. So there has been initial research, this is in June of 2016 where this was published, that has shown that in seizure cases, we can in fact measure and see differences in brain regions of hypo and hyper connectivity. So here what we see, let me get my pointer again. In the orange locations you see down here are regions of hyperconnectivity where they believe in limbic, parahippocampal gyrus, and temporal locations, the seizure events are showing discharges, but you see regions of hypoconnectivity in posterior temporal and anterior frontal regions where the region itself across that entire area becomes disconnected. And the result then becomes the hyperexcitability of the one focal region that leads to a seizure event. That's very important. Another study published in 2013 in Frontiers in Neurology, again, looked at fMRI connectivity in cases of seizure disorders. And again, you can see in red, there are regions of hypersynchronization and connectivity, deep in limbic structures, which is where many seizure events are kicked off, and regions of hypoconnectivity along cortical stabilizing, hopefully regulatory regions that would inhibit those types of activity. Here is another project that looked at structural and functional brain networks in temporal lobe epilepsy. And they showed very similar findings where, again, the orange areas were regions of hyperexcitability, and the blue areas hypoconnectivity, and the actual red areas in here were events where the seizure events were localized to and actually took place. Obviously, these were people under surgical procedures where they could demonstrate this. But what they, again, theorized is that this loss of connectivity actually led to the hypersynchronization of the seizure events. This, as you can see, is in deep limbic entorhinal cortex and temporal cortex surrounding it. Another study published in 2013, again, very, very similar findings. We see this repeated over and over again, where we have hyperconnectivity measured in temporal limbic regions, predominantly on one side more than the other, but in some cases you actually see that from side to side. And then hypoconnectivity from more cortical temporal locations to those limbic regions. We published a study in 2015 where we looked at neural connectivity measures in epilepsy patients as measured by a technique called Granger causality, which you'll hear a little bit more about in a few minutes. But basically, this is a technique where you can take the EEG, use complex processing software, and then use a measure of source localized three-dimensional autoregressive statistics called Granger causality that measures connectivity across regions. And you can isolate regions involved in seizure activity itself and their connectivity. And you can measure these as they evolve over time. So we take the EEG file of an individual with seizures, and we isolate only the seizure activity itself. So we delete everything else. And we look at the evolution of the seizure events. And then we can measure the changes across time and connectivity. So up here you see at time 1 image before a seizure event kicks off. And time 2 and 3 are when the seizure event is happening. So what happens during that event? We see a hypersynchronization of the left temporal parietal region and a movement towards lower connectivity in regulatory structures from frontal and central sites. Okay. I thought I got logged out for a second, but I'm pretty sure I'm back on and you can all hear me. So then you see a dip of connectivity from here to here, which then allows the discharge, the separation of this segment of neuronal groupings to get into this hyperexcited, hyperconnected seizure state. As the seizure winds down, you see that connectivity decreasing, connectivity in frontal regions increasing, and then we go back to a more stabilized state. So we can actually measure during the seizure event itself the change in connectivity. And if we could prevent that from happening, theoretically, we could prevent the seizures from taking place. This is another individual of a person with a partial seizure disorder over the right hemisphere, where you can see here and here the discharge, the hyper synchronization over right frontal and parietal regions, and how there is a dip or lower connectivity between those regions. And again, if we can enhance that connectivity where you see here, the likelihood of those hyper-synchronized states becomes much less so. So taking that theory into effect, we then pursued a research study looking at, can you use coherence training and neurofeedback to train seizures? So we know that there is already a literature of using neurofeedback for seizure disorders. This was the result of the meta-analysis study done by Tan et al., published in 2009, that looked at a series of multiple studies and cases. You can see the 10 studies listed here that were included in their meta-analysis. And they found that there was an effect size for what is basically SMR training. They include one slow cortical potential study, but the majority of this is SMR training. And they found that they were able to significantly impact seizures at a moderate effect size. Usually anything above 0.5 or 0.6 is considered a moderate effect size. Barry Sturman, who coined this type of intervention, also reviewed the literature and found that 82% of patients had more than a 30% reduction in seizures, the average reduction being 50%. To date, there have been no other published group studies examining other types of neurofeedback for seizure disorders. So while we may talk about other types of neurofeedback, there essentially is no other research documenting efficacy up to this point. So we studied 2 separate groups over time, in which one group received 2-channel bivariate coherence training between 2 sites, and the other group received 4-channel multivariate coherence training. There were 26 patients in each group. Of course, they were all designated as having seizure disorders. Some of them also had a comorbid diagnosis of autism, some of them did not. They were all treated with QEEG coherence-guided training, where obviously we knew they had seizure disorders, we identified their seizure events, and ran QEEG analyses like we've talked about to identify the region of dysfunction for training. The 4-channel multivariate coherence training setup is something that we created with Eager and Howard Lightstone as the engineer about 4 or 5 years ago. And it involves the demarcation of 4 electrode sites on the surface of the brain. And we measure multifactorial, multivariate coherence patterns across all 4 locations, so that we take into consideration the coherence patterns among all possible pairings. So when you measure a pair of coherence values, for example, like most QEEG software platforms do, just measuring between a pair has a lot of statistical error built into it. And in fact, about 50% of those values can be accounted for by neighboring locations. And these statistics themselves have been shown for the past 10 years to be an underrepresentation of the true connectivity patterns. So we know that pairwise coherence analysis can be somewhat misleading and inaccurate, and that multivariate techniques are much more accurate. So we move to pursuing our training in a similar fashion, where we take the coherence value between A to B, A to C, A to D, and we average that value at A. We do the same thing for B. So the relationship from B to A, B to C, B to D, and we average that. The same thing happens at C and D. And then we take the average coherence value over the entire field where we're measuring the EEG activity. And that becomes our reward band, where we're trying to train coherence up with the idea that that will diminish the potential for seizure activity. At the same time, we're training coherence up over these 4 channels. We're also inhibiting amplitudes. And the most common amplitudes, as we talked about, from the spike and wave discharges, is there's most commonly a very slow wave inhibit and a high alpha or low beta inhibit, and there might be an EMG inhibit as well for someone's individual protocol. So the training is always a combination of inhibiting amplitude and increasing or rewarding for higher coherence values across these regions so that the system is better connected. So of our patient grouping, which again had 52 total patients, 26 in each group, these are the seizure types. 13 of them had generalized epilepsy, 18 temporal lobe epilepsy, 8 absence seizures, 6 benign Rolandic epilepsy, which are mainly motor seizures, and 7 other simple partial seizures. So you can see that the majority of the group has partial epilepsy. There are some with generalized epilepsy as well. These are our basic demographics. This is the age distribution, which went all the way from about 6 years of age up to 70. The greatest number of individuals were teens from about 7 to 18 years of age, but there are other individuals throughout the age groups as well. Our male-female distribution was about 2/3 male, a little bit higher than that, and the others female, of course. Most were right-handed, about 90%, and the others were left-handed or ambidextrous. And a lot of the data we collected was from our own clinics, but we also worked with multiple clinicians in multiple clinics throughout different parts of the country and trained them to follow similar analysis procedures, most of which we did for them, and similar intervention procedures so that this was standardized across clinics. And in fact, I believe there are up to 11 different clinics where data was collected. And when we ran our analyses, there was no difference across any clinic. So the same level of efficacy can be garnered by anyone as long as the analysis and the treatment approach is standardized. So there's nothing unique about one clinic over another per se. In terms of medications, we had about a 50-50 split, where about half our patients were taking medications and a little more than half. And then 31 of the 56 were not. And here's the breakdown of 1, 2, and 3 or more medications. So you can see that breakdown there. But the groups are fairly evenly divided. The treatment group, of course, is even. There were 26 subjects in each group. Again, the analysis portion, before we start the intervention, can involve several different levels of analysis of the EEG. The first, of course, is to identify seizure events, which you see here. The simplest way of analyzing coherence is through a software suite called NeuroRep, which is a multivariate approach based on principal components analysis that takes input from every electrode site compared to every other and gives us the deviation or unique deviation in coherence across regions. So for example, in this case, when you see a big space like this, and this, and this, those are areas of very low coherence. When you see things sort of piling up, those are areas of high coherence. So we can identify here, in this case of a focal left parietal temporal seizure disorder, a hypocoherence across those regions, and we can decide to train coherence across those sites to enhance coherence, again, in the hope that their seizures will diminish. So that's one approach. We have several different techniques at our disposal to look at what these seizure events look like. Another example is a program that was created at the beginning of this study, which was called Spectral Sort. This is a program where you can take a single EEG that shows seizure events. You can, again, isolate all the seizure events, and then you can run it through this program where the events are occurring. Remember, this is our temporal parietal focal seizure disorder. You can isolate the frequency you want to look at and the magnitude power or relative power aspect, and then run this program. And what it does is it isolates a median value at each location, and it divides the EEG into two EEGs, where there's a high value and a low value EEG. So now our high value are the peaks you see here, where the seizure events have a higher amplitude. The lower value are still seizure events, they're just a very lower, much lower amplitude. And we can then compare those two EEGs for changes in coherence, where you can see, in our case again, we can isolate a region of connectivity. So of lower connectivity. So what does this mean? This means that when we go from low amplitude to high amplitude seizure activity, the change that accompanies that is a dip in coherence over the temporal parietal area to frontal area where the seizure events are occurring. And again, this gives us a roadmap we can follow to train coherence up over those areas to hopefully prevent these seizure events in the future. So that's another way of looking at similar information. The third way is the way we talked about earlier, which is this method called Granger causality, which takes an individual and their EEG. So this is a 7-year-old, 7.5-year-old boy who was diagnosed with autism, but also with Lennox-Gastaut syndrome epilepsy, which for those of you that are familiar with it is a highly treatment-resistant form of epilepsy. You can see he's on multiple medications. This is his EEG, where you can see multiple different types of discharges. We take that EEG and we process it in a program that uses independent component analysis to extract the significant components associated with the seizure events. we can then source localize those events to these regions of the brain. And we can largely see they're over left temporal to frontal sites, although there's one on the right side. We can then take this information, use S-Loretta database analysis. This one is at 3 Hertz to see where is that activity occurring and what is the Z-score. We've got a Z-score here of over 7 standard deviations above the mean, with a localization in bilateral temporal and limbic structures, even down to the uncus, which is a very deep region in the limbic system associated with severe emotional and behavioral dyscontrol. And we can identify regions of the brain that are being impacted, and we can identify sites that are source localized that are impacted, and then we can run connectivity analyses to look at those regions over time and how they change. So again, we see during seizure events, for example here, where the right hemisphere gets hypersynchronized. Other times, the left temporal lobe gets hypersynchronized again and again. But in the middle of all that is this very dense region of hypoconnectivity that almost never changes. In fact, again, you'll notice when we get more hyperconnectivity, we get more hypoconnectivity between those regions. You see that there, you see that here. When they become more hyperconnected, this becomes more hypoconnected. You see the same right in here. Very dense areas of hypoconnectivity. So the hypoconnectivity ratings, we're talking about a connectivity metric which goes from 0 to 1. The hypoconnectivity in all of these values is about 0.04. So if you think of that as a correlation statistic, which is what coherence largely is, that is extremely low. That means there's almost no crosstalk across these regions to regulate and prevent these discharges from occurring. And we can identify that, and then we can target those areas with our neurofeedback to attempt to improve function. Okay? So using one of those techniques, which is very commonly what we use, we then performed this study where we had 2 different groups. Again, 2-channel coherence versus 4-channel coherence training. The 2-channel trained group had an average of 20 sessions per subject. The 4-channel group had an average of 14 sessions per subject. One of the things we noticed in doing 4-channel training right away is we can usually achieve the same benefit, if not greater, in a smaller number of sessions. So we have limited the number of sessions that we look at, whereas typically for 2-channel training, we would always do 20 sessions and then do a reanalysis. Again, we can use this EEG platform from Persist to look at EEG events that you can see all throughout here. They will detect not only spike events that you see with each of these hash marks down here, but seizure events that you see in red. So in this particular case, this is a woman with an absence seizure disorder. During this only 10-minute recording, we identified 4 different discrete absence seizure events. Before her training, following her training, you can see that there aren't any. And you can see the number of spike events has reduced as well. So this is the benefits that we often see with this approach. So when we look at seizure events in the 2-channel coherence trained group, again, over 26 subjects, we see an average of 126 seizure or spike events in a 20-minute recording time. Following the 20 sessions, we see that go down to an average of 46 events. which is, of course, statistically significant and very, very important. It's almost a reduction of somewhere close to about 60% or so on the average. Many of these people were on the autistic spectrum, and we saw their autistic symptoms drop by a third during this time period as well. So we know that the two-channel training helps, but what we want to do is we want to compare the degree to which, how it relates to the four-channel training as well. Okay, so we looked at our two groups, and basically there are no difference in handedness, in medication usage. There was a little bit of a difference in age, medication usage. Gender was not significantly different. So we then looked at these different variables, and the only one we found to be significantly predictive of outcome was seizure medications. What you'll see a little bit later, I think, is that that prediction was not in the direction you would want it to be in. They didn't always predict positive outcomes, because with more medication, the neurofeedback training was not as effective, but I think we'll get to that a little bit later. So this looks at seizure change between the two groups, where we can see that there is a statistically significant difference. And this is done per session, okay? And again, this is looking at medication usage down here. And we can see that better outcomes in seizure change were associated with no medicine. That was actually the best outcome group. And the one seizure med, two seizure med, they still improve, just not to the same degree. Now, the thing you have to realize is these people came in on these seizure medications. Many of them have been on it for years. So now we're talking about the added benefit of neurofeedback and if that changes things. So what this tells us is that neurofeedback works best when there's no medication involved, but it still works when medications are on board as well. Our next slide looks at seizure change between the two groups. And there is a statistically significant difference where the two-channel trained group had an average percentage seizure change over the entire course of training of 56%. So they had a 56% reduction in measured seizure events from time 1 to time 2 over the 20 sessions of the two-channel training. The four-channel group had an 81% reduction in seizure events from time 1 to time 2. Again, this is only over 14 sessions of training. So we have fewer sessions, but we have a sizable increase in the proportion of change. And that difference is statistically significant. When we look at that change on a per session basis, that's what this is. The two-channel training group had a percentage seizure change of about 3% per session, and the four-channel group about 6.25% change per session. And that difference is more than double. We then looked at change in coherence over the course of training. So in fact, we showed that coherence adjusted, which is coherence change over time, was 23% in the two-channel group from time 1 to time 2, 146 over the four-channel trained group. Now these values are over multiple regions, so you may have 5 or 6 regions that add up to this total, which is why you can get such a large number. But we looked at the same thing for both groups, and of course there's a sizable difference here this is of a magnitude of, 5 or 6 times the effect. This is coherence change per session. And in fact, you can see per session, there's an 11-fold enhanced ability to change coherence patterns in 4-channel training as there is compared to 2-channel training. So the theory that using multivariate measures and strategies may give the brain more accurate feedback and then may lead to increased outcome was clearly verified by these findings. This now looks at change in power. So one of the things you want to do in a seizure disorder, of course, is you want to see the amplitude going down as the seizure events go down. So clearly there was significant difference between the groups in power delta or power change, and in power per session was significant as well. In the 2-channel group to the 4-channel group, again, there was about a doubling of the effect. So the coherence patterns change more so, which was an 11 times effect, but even power changes are a double effect, which is more significant, of course. We then did a regression analysis using a model to predict change and using change in coherence and power per session as the predictors to predict seizure change per session. Our model was statistically significant with an adjusted R square of up to almost 0.4, which means we're accounting for close to half the variance, and that changes in coherence and power are significant predictors of changes in seizure events. So that the neurofeedback itself and the change that it's causing, we believe, is significantly predictive of the change in seizure events. These take this study compared to other effect sizes. So what you see here is a group of studies put together in 2001, a meta-analysis of anti-epileptic drug effects. Now, there may be a more recent study that would give us better outcome, but the average outcome was an effect size of 0.5. We know the average effect size of SMR training is about 0.7. The average effect size of our 4-channel coherence training was 0.9. So while this is only one study and much more work needs to be done, it looks like a very interesting, possibly efficacious way of intervening, and a way that may have some advantages over other techniques we have used in the past, or something we might want to use in addition to those techniques. Again, if we look at average reduction in seizures over time, we see the SMR is about 50%. 2-channel coherence training by itself is slightly above SMR training. And 4-channel multivariate coherence neurofeedback is at 81%. Again, that's only in 14 sessions. With more therapy, there is more gain. So that's what all of that information looks like. I want to thank you all for attending. You can locate more information about some of the services that go into analyzing EEG through our website. We even have a workshop coming up in March where we can train people to do the analyses and to do the training itself as well. So if anyone has any questions, I'll be happy to answer those in about the 5 or 6 minutes we have remaining. If you would put those questions through the Q&A feature, that's probably the easiest way for me to access that. Okay, I don't see any questions right now. I'm not sure that function is working entirely. If you prefer to use the chat function to ask any questions, that would be great as well. If there aren't any questions, I thank you all for attending. And if we can help anyone with approaching things in this way, we'd be more than happy to. Oh, good question. What is known about the duration of effects after training stops? Very good question. We are in the process of collecting data on that. We know from studying other patients that where we've studied them for as long as 3 or 4 years after training stops, that the effects of training do not go backwards. In fact, there are long-lasting effects of training. That's true in autism, it's true in learning disabilities, it's true in other conditions. We have not yet pooled all the data related to epilepsy. I can tell you from individual cases that we know of, I can't think of a case where we stopped the neurofeedback and the seizures came back. But we certainly look to gathering more data to answer that question. What is the risk of worsening seizures in early going if take patients off meds to get better effect? Good question. Again, we don't really know the specific answer to that. What we typically do is we start the training with them on the medication and wait for a reduction in seizures. Once we get a significant reduction, we then work with the patient, their prescribing physician, usually their neurologist, sometimes an epileptologist, sometimes a psychiatrist, to then gradually diminish seizure medications while they're in treatment, so we can look at the effects of that. Okay, other questions. What types of seizures is neurofeedback most effective for? So in this particular study, the predominance of our seizures were partial seizure disorders. So we know it's quite effective for that. But there are also a group of about 15 subjects that had generalized seizures, which also benefited. So we believe there's efficacy in several different groups of seizure disorders. Of course, some seizure disorders that are more challenging, like I mentioned, Lennox-Gastaut syndrome is more difficult for anything to treat. Outside of that, we've not experienced a non-responsive group per se. The next question was, as I understand it, you compared 2-channel to 4-channel. There is no placebo or only medication group. That is, in terms of what we presented, that is true. All the individuals that presented, about half of them had been on medications for a period of time prior to the seizure study. And we do have data from them and their neurologist about that. And we do have data from other studies looking at medication effects. And basically what they find is that, of course, medications do reduce seizure events. They don't reduce them entirely all of the time. And in about a third of the cases, they don't work at all. So a lot of people have talked about using neurofeedback in those cases, but it's my belief that neurofeedback can help in cases even where medications are effective to reduce the seizures even beyond the effects of medications. And the last question is about publishing, which we certainly hope to do in the near future. All right, looks like we're out of time. So thank you all very much for attending, and that'll be the end for today. And I hope everyone has a nice weekend. Bye-bye.